Great. Well, thank you for having me. It's an honor to be able to help out with some of the training program for all of you here. My name is Marc Pimentel. I'm an anesthesiologist at Brigham Women's Hospital, and I'm a medical director in quality safety and associate clinical director for quality anesthesia. And today we'll be talking about pre-op evaluation, prehabilitation, and perioperative quality safety. So we got a lot to go through, but this will be a fun ride. Okay. I've got no disclosures to make. I don't have any financial ties to any companies, but I do want to thank some of my mentors and colleagues, Angela Bader, David Hepner, and Matt Mosselman for helping with the selected content and some of their advice. So today we'll be talking about preoperative evaluation. We're going to identify several key factors in preoperative evaluation, how to get patients ready for surgery. We'll be talking about prehabilitation. It's a very up and coming concept where we get patients tuned up before they go for surgery from a physical and mental point of view. So we'll be able to describe the overall concept of this after this talk. And we'll be talking about quality and safety in the peri-op area. You'll be able to learn about a way to think about quality improvement projects and a couple of areas that we all have to watch out for in quality and safety. So first, pre-op evaluation. So let's start with a case. Let's say a 75-year-old man comes in. He has a elective hernia repair scheduled for next month. This is kind of still have 30 days to go, but he's got diabetes, metformin. His body mass index is 30, so he's gained a little bit of weight. He smokes a pack of cigarettes every week and drinks one glass of wine with dinner. Sounds like a pretty typical kind of patient, at least over here. I know you see over there, but it's pretty typical here. Is there anything that he needs to do before surgery? See some nods here.
He needs to stop smoking before the surgery, a month before the surgery.
Yeah, exactly. So
the alcohol.
Yeah, smoking, probably the alcohol. Those two things should go before surgery, if at all possible. So some of those recommendations are based on this work around post-op wound complications among patients who smoke. And there was an ISQIP National Surgical Quality Improvement Project database study of over 4 million patients and how they did after open surgery. And they found that smokers had increased mortality, increased infections, increased wound dehiscence, pulmonary complications, and increased length of stay. So for all these reasons, it's really helpful if the patient would stop smoking for the month before surgery. So it's also been shown that quitting smoking 4 to 6 weeks preoperatively and staying smoke-free afterwards for 4 weeks will decrease wound complications by 50%. As we all know, cigarette smoking it's not good for perfusion and introduces toxins to the body, so that would impede wound healing. So for those reasons, we recommend him stop smoking, and if you can, maybe no drinking. But that gets us to the bigger question. What's the purpose of preoperative evaluation, and what's the point of it, right? So what we can do with preoperative evaluation is to reduce the modifiable risk. So when patients undergo surgery, there's bad things will happen to them, whether we do something or not do something. Sometimes that's just the state of taking care of patients, but we take the risk of these things happening, and some of these things are intrinsic to the patient that you can't change. So the patient's age, you can't change their age. You can't change some of their disease states. If they only have one lung, they're not going to have 2 lungs on the day of surgery. But there's some things that are modifiable, things like the smoking, the drinking, their physical fitness, their mental health, their medication compliance, their blood pressure control. A lot of these things can be modified, and to the extent that we can reduce the risk from these, we should. Okay, so a lot of the following content after this is taken from Preoperative Assessment Management 3rd edition by Bobby Jean Schweitzer, who's a leader in this field for assessing patients before surgery. So getting ready for surgery, it's much like getting ready for a big trip, a long vacation, or maybe not vacation, so maybe I'll call it like a business trip, all right? So we are going to be assessing the patient, getting their history, doing the physical exam, learning about all the different conditions that they have, their allergies, trying to figure out what's their perioperative risk, right? And before we proceed with surgery, we ask the question, are you ready for surgery? Should you even have the surgery based on your risk factors? And once we get past that, we also use preoperative risk assessment to figure out how should we take care of them on the day of surgery, right? What have we done up until the day of surgery to get them ready? So that's stopping smoking, stopping drinking, get their medications in line. And then on the day of surgery, how should we take care of them in terms of their anesthetic, their surgical technique? Should it be open? Should it be closed? Should it be closed, like a laparoscopic or possible open surgery? Should they have a spinal anesthetic instead? All these questions can be informed by a good pre-op assessment. And then after the surgery is done, the pre-op assessment is also good for telling patients about their post-operative care plans, arrange for care at home if they need to be taken care of at home by a nurse or by family, what they should be doing after surgery in terms of eating, drinking, lifting weights, activity, and so forth. So all these things can be influenced in a positive way by a good preoperative assessment. So medically speaking, there are a whole bunch of things that patients can come in with, and not all of them need to have an extensive preoperative assessment, but this is a list. I think I'm going to share the slides after, and you have the recording. But any patients who have any of these conditions from head to toe should really have some type of preoperative evaluation before day of surgery. Because if they just show up for the first time on the day of surgery and they have end-stage renal disease or they have some type of coagulopathy that should have been addressed or fixed or worked up, that can really lead to some delays in care and patient has to come back, or if you choose to go forward, there'd be some extra modifiable risk that we kind of accept to go with. But some of the big items that you want to watch out for are patients with atrial fibrillation, especially if it's not controlled well, and hypertension, heart failure, patients with kidney failure, patients with history of difficult intubation, or if they have abnormal airway anatomy, and patients who have any of these anesthesia-related problems. Just want to point those out: the malignant hyperthermia or problems with paralytics, like pseudocool masturbation deficiency. If you see any of these things, it's worth it to go work with your preoperative team and get them assessed before the day of surgery. I just want to ask, actually, what is your process for seeing patients ahead of surgery? Do you see them ahead of surgery, or do they come in the night before, or do they go into a clinic the week before?
Anyone wants to explain what's happening in their hospital with pre-op?
So if this is an elective procedure, the patient comes before, and maybe the doctor who is like in clinic or in hospital who's doing examination, he's writing some prescription for some exams and stuff, asking history and all of that. And a few days later, when all of that ready, patient comes to the hospital once more time and maybe gets a re-evaluation.
And Andrew has his hand raised up. Oh,
I think you're still on mute.
Hello. In our hospital, the patient has maybe the same access before surgery, but when he came for evaluation and planning the date of surgery, the anesthesiologist access the patient and give his recommendations for this patient, and he has time before surgery to make these recommendations.
Okay, got it. All right. Yeah, so every place is a bit different. Some places will see the patients way early, some not so early. I think a long time ago, we used to just see patients on the day of surgery. Other times we would admit them the night before. But for the most part, we have a phone call with the patients and a virtual visit. But we'll get to that soon. Very good. I want to stress the importance of the history and physical exam. So taking a good history will give you up to 73% of all the diagnoses that you want to be thinking about for prep evaluation. It's not based on expensive lab tests or sending patients for special procedures just to go see their chest radiograph or their CT scans. Most of these things for prep evaluation can be found with just a good history and physical exam. Okay. And I want to introduce you to the ASA physical status scores. Do you guys use these? International, the ASA 1, 2, 3, 4, 5. If not, that.
Yes, they are commonly used by physiologists.
Okay, great. So I won't get in too much detail with this, but the part that you should know is ASA 1 patients are the very healthy, not sick at all, having elective surgery. They don't even smoke. I find ASA 1 patients are very rare to find these days. So super, I don't know, maybe it's just also I work at, but you'll find that these very healthy patients, maybe they're mostly seen in the community centers, but when you come to a big academic center, most of your patients are going to be ASA 2s at least, who have some smoking, maybe some drinking, or diabetes or hypertension that's controlled, maybe a little bit of asthma, but really nothing to write home about. A lot of patients are going to fall into this kind of middle area with ASA 3. So they've got some hypertension that doesn't have the greatest control, or they have COPD, they have maybe a mildly reduced ejection fraction, and maybe their BMI is over 40. So a lot of patients fall into this category. And then we move on to ASA 4 and 5. These patients with more severe disease, where they're always having a constant threat-to-life issue. So if they have ARDS, they have disseminated intravascular coagulation, or they have end-stage renal disease, but they're not on dialysis, or if they have stents with ongoing ischemia. These are the ASA 4 patients. And then ASA 5 patients are even worse. So they might not survive without surgery. And ASA 6 is just a code for patients who are brain dead and they're going to be donors for organs. But why are these scores important? It's because they're actually a predictor of mortality at 48 hours and beyond. So this is a study that showed that the ASA physical status, it kind of scales up. So when you have ASA class 1, 2, and 3, it's mostly, most patients don't have a problem with mortality. But when you get to ASA 4, ASA 5 patients, and the red is the emergency, like 4E is the ASA 4 patients having emergency surgery, or ASA 5 patient having emergency surgery, these patients tend to have very high mortality rates, anywhere between 5 and 20%. So it's a good way for the team to communicate around how serious is this case. Do you have to be on high alert for this patient? And this was validated in cases back from the 1970s. So we've been using ASA scores, I think, since the 60s, and it remains applicable today. So in the green is a more contemporary patients and ASA scores, and the orange is also mortality rates with different ASA scores. And what we found is that back then there was more kind of this gradation in the mortality rates between higher ASA scores, but nowadays you only see appreciable mortality when you get to ASA 4 and 5. So keep using the ASA score. So when the anesthesia team says that the ASA score is 5, that should make your ears tickle a bit. All right, so let's say the patient came in and they had their physical exam, the history done. What about lab testing? Don't we need to do some labs? And actually the answer is no, not necessarily. Most patients don't need lab testing. The lab testing shouldn't be done on all patients. Things like drawing the hematocrit, hemoglobin, the urinalysis, the electrolytes. You don't have to do, you shouldn't do this for all patients. You should only pick the labs that certain patient populations need. So for example, we shouldn't be doing chest x-rays on all patients when they come in for their laparoscopic appendectomy. You should only be reserving chest radiographs for patients who have something to find there. Patients who have some shortness of breath, or if they're having dyspnea when they're lying down, you get chest radiograph for those patients. Or for hemoglobins, it's nice to know certainly what the hemoglobin is for our cases, but if you're not going to be losing a lot of blood during the case, or the patient doesn't have any history of bleeding or anemia preoperatively, there really is no need for drawing hemoglobin. And the same goes for these other tests. Coagulation, I wouldn't draw a coag panel on patients who don't have a reason to have any abnormal bleeding history. Same for electrolytes and urinalysis. That's still pretty popular these days, but it's almost never actually indicated. Sometimes we still draw urinalysis for patients having some like orthopedic surgery, but rarely do the implants post-operatively. They rarely get infections from anything that grows from the urine. It's usually something from the skin. And then pregnancy testing only from a childbearing age, if it will change management. So I wouldn't necessarily draw a pregnancy test in a patient who's having emergency surgery, because we're going to be doing the surgery kind of either way. This goes double for blood transfusion. So when we think about drawing a type and screen prepared for patients who need blood transfusion, not all patients really need to have type and screen a sample. Only if they're going to have a case that would require such a thing. So for example, these are our recommendations that we use across our hospitals for picking which patients will need blood and how much to prepare. Patients that were having just hand surgery or having foot surgery or having inguinal hernia repair, they don't even really need to get a type and cross, type and screen, because they're very unlikely to need any blood. And if you did need blood, you could ask for emergency release type O positive blood, type O negative blood. And then for the bigger surgeries, of course, you would draw this, but this just goes to show that you don't need to draw this blood sample for all patients, because it ties up resources and can lead to delays. Another popular item in pre-op testing is the preoperative EKG. Does everyone need a pre-op EKG? No, not everyone needs one. So here's an algorithm for figuring out which patients need an EKG. If there's any concern for cardiovascular disease, that they have symptoms like shortness of breath, or they can't quite go up the stairs the way they used to, that's cause for doing a pre-op EKG. And for patients who don't have any signs or symptoms of cardiovascular disease, and they're having a low-risk surgery, they don't need an EKG. But there may be some patients who have no signs or symptoms of heart disease currently, but they do have some risk factors, like they have uncontrolled diabetes, with older than 65, and maybe have like a peripheral arterial disease somewhere. I would get an EKG in those patients. So I just want to double down on this statement that unnecessary lab testing is wasteful and leads to delays in care. So to the extent that you can limit the lab testing to only what the patient really needs, it's better for everyone, because you don't have to send the patient to the clinic to go get their blood drawn. You don't have to follow up any false positive results, because if you draw something and it says, oh, they have anemia, then someone else might want to ask to get the whole anemia panel and do an anemia workup, but the patient is only having a foot surgery or a hand surgery. So it's important to be very mindful about the labs that you send. Okay. So let's say we saw the patient, we did their history physical exam, we did any necessary lab testing. What are you going to do with all that data? What if we're worried about this patient? And how can we figure out what is their risk? So, because there's so many papers out there about, the risk of death, the risk of intubation, risk of sepsis after surgery, risk of infection. You can't keep up with all of it at once. So there are these very handy risk assessment calculators on the web that you can use. You can plug in all the patient's different parameters, like if they were what their ASA class is, their age, if they have heart disease, hypertension, diabetes, renal failure, all these things, and plug in the type of procedure that you are going to do for them, and it will give you this nice chart of all the different complications that they could have and the risk for each one. So I had plugged in our 75-year-old man who had diabetes, of smoking and drinking, and having a hernia repair. And over here in the outcomes, it says that he's at elevated risk for any complication, so 11.6% risk, where the average risk is only 6.7%, right? He has a very low risk of death, but he is at some elevated chance to be readmitted post-operatively. And then because of his age, we also pull these geriatric outcomes, which are becoming more and more important. He has a 66% chance of functional decline, or more than 50% chance of needing an aid to get around, some type of like a walker or crutches or something. So this is important both for us, for booking the surgery, decide to go forward with surgery, and to have an honest conversation with the patient as to, do they really want to have the surgery knowing that they are at risk for some of these complications, especially if maybe stopping smoking or doing some prehabilitation can prevent some of these things from happening. Do they want to have surgery at this time? Should we delay surgery, or should we just go ahead knowing that there's a risk for all these things? So if you haven't seen this before, I urge you to go check it out at riskcalculator.facs.org. That's the American College of Surgeons website. Something just to talk with your anesthesia colleagues as well is preoperative fasting. Do you guys use the preoperative fasting guidelines there? 6 hours for a light meal and 8 hours for big, heavy meals? Sometimes.
Yeah, we use it.
Yeah. So the latest recommendations, which I think haven't really gotten around even in my hospital, is that patients can have clear fluids up to 2 hours before surgery. So let's say the patient has surgery scheduled for 3 o'clock in the afternoon, and traditionally we would make them NPO, so don't eat or drink anything at midnight the night before. So they go an entire day not eating or drinking anything, and then we give them anesthesia at 3 o'clock, and then they drop their blood pressure because they're just so dry. This can be somewhat avoided, right? If you can just let them drink clear fluids if they're thirsty up to 2 hours before surgery, that could be a good thing. And there's some ERS practices that we do, enhanced recovery after surgery practices that we do to help get this done. We give our patients something called Clear Fast, or one of those carbohydrate drinks. I think you probably hear about this in one of the other courses, but it's been shown to help with motility of the gut and make sure that the anastomoses are good, because we feed the gut a little bit. So here's a slide just about unnecessary fasting for these patients. The origin of NPO after midnight actually came from the OB literature, the obstetrics literature, where patients would frequently aspirate under general anesthesia. And it was generalized to all patients back in the 60s, and it's just kind of been like that ever since. We've been doing NPO at midnight since the 60s, and it's kind of like a hospital tradition. So as we discussed, it's kind of unnecessary, but also at the same time kind of tricky. Sometimes you don't know exactly what time of day the patient's going to have their surgery, especially if they come in as an emergency and they're not really scheduled, but they don't have to go right now, but we're going to try to fit them in the OR schedule sometime later tomorrow or later today. Frequently these patients just end up being NPO the entire day, and if their case gets delayed or rescheduled, they get NPO for a couple days in a row, and that's not good for anybody. I don't know if you guys had any any solutions to that in your own institutions, but if you think of one, let me know. So putting it all together, this is our, just want to show our preoperative evaluation process that we use at the Brigham. So when the surgeon books a case, 1 to 2 weeks prior to surgery, we're going to have the pre-op nurse is going to do an assessment via chart review and determine if the patient needs a virtual visit by Zoom, or if they just need a phone call update. So if they had surgery recently and we have all their records, they might just need a phone call update. But most patients will get a virtual visit, or we're going to gather all their medical records. We're going to go review their medications with them. Are they taking their medications? And ordering additional testing if required 1 to 2 weeks before surgery. The 2 weeks before surgery, especially for older patients having orthopedic surgery or high-risk patients, we need 2 weeks to get them ready. And then after that, we bring all the data together and we figure out a plan with the surgeon and recommendations for the anesthesia. So then we proceed with their care. So that's how we do this over here for most patients. Of course, there's always going to be an emergency patient who comes in the middle of the night, and all this stuff just kind of goes out the window. But for the scheduled cases, this is what we usually do. All right. Any questions about pre-op evaluation before I get to prehabilitation?
I have a quick question.
Yeah.
When do you do this assessment plan? Do you do it after the Zoom meeting? But how do you check the airways for the intubation and everything in that way? Or just if you skip some, I don't know, signs that can be, I won't be able to see it through Zoom.
That's a great question. So for most patients, they just have a kind of a virtual visit, and the nurse does this. So they can't really do a full physical exam over Zoom. They do the history and the medications and getting outside records. If they have a suspicion based on the patient's weight or their previous airway records, we would ask that they maybe send us a picture or do a Zoom with the anesthesiologist. But it's usually the anesthesia team on the day of surgery will assess their airway and do the full physical exam there. So that we used to have an in-person center all the time, but because of COVID, it all went virtual. And some patients found that to be actually very convenient for them because they didn't have to drive in to the center for a few hours to go get their evaluation done. But at the same time, it kind of limits our ability to do a full exam. Alexander, question?
Yes. And what medications that patients routinely administer, they administer in the day of surgery?
On the day of surgery, like what?
Mm-hmm.
Like heparin?
No, like metformin or like thyroid hormones.
Oh yeah. So for most of the medications, we tell the patient to just continue taking whatever they've been taking most of the time. There are some exceptions to that, and sometimes it depends on the type of surgery. So for example, if the patient is taking ACE inhibitor, like lisinopril, we'll tell them, oh, don't take your ACE inhibitor the night before because you're going to be having cardiac bypass and you'll have, untreatable hypotension. But for most patients, we just tell them to continue their medications. If they're on anticoagulation, that may have to be adjusted prior to surgery or several days before surgery, like if they're on warfarin or Eliquis or any of the other directed inhibitors. So that's why it's important to have this at least this phone call and a virtual visit to make sure all those things are in place so that on the day of surgery, you don't have to cancel the case or reschedule the case just because they took their Eliquis by accident. Sophia.
Yeah, thank you for your time. And my question is, what should we do if our elective surgery patient become an urgent one? For example, if we have an elective herniatomy and it's become a strangulated one, how should we evaluate the new situation at this time?
So it frequently happens. The patients will come in for their elective case, and then all of a sudden it's a bit more serious than it was before when we were assessing it. Usually we call the on-call anesthesia team to go assess them quickly and see if they need to have an emergency booking in the OR. But at that point, we don't have our pre-op center be involved because they're most of them are remote now. So this is all done in person pretty quickly, but they still focus on most of the same things. The history, physical exam, any labs. I think they're a bit more liberal with taking labs when the patient's already here. But it's kind of left to the anesthesia team and the surgeon who are there. Victor.
Yeah, could you please tell me, in your hospital, what is their, let's say, average preoperative workup for a patient, let's say, about 65 years old with no history of myocardial infarction, stroke, maybe some hypertension, and that's it. And the patient is undergoing an election surgery for cancer, let's say colorectal resection or gastric resection. So he or she has only hypertension in comorbidities. What will be the workup in terms of labs, EKG maybe?
Yeah. So because of his age and hypertension, we would likely get an EKG for this guy. And because of his oncological surgery, the potential for bleeding, we would get his electrolytes and hemoglobin and a typing screen because he's at risk of getting a transfusion. Other than that, if he has good functional stats, if he can take 2 flights of stairs, he doesn't have to do a stress test or a cardiac echo or any of those things. And EKG would be fine. Okay, I think I do have to get on to the rest of the talk. So let me just hold questions to the end. So we're going to talk about prehabilitation for a bit. So this is a relatively newer concept in pre-op evaluation, but prehabilitation improves the functional capability of a patient before surgery so they can withstand a post-operative inactivity and associated decline. Because we're taking these patients who, they may not work out every day, they probably don't work out, they may not even take the stairs every day, and we're having them have this big surgery, and then we tell them, well, you can't walk, or you can't do anything, you can't lift any weights, you can't even dress yourself maybe for X number of days after the surgery, and this could go on for weeks. They're at risk of having poor outcomes, right? They're at risk of falling down the stairs. They're at risk of being readmitted for delirium if they don't keep up with their meds and all. So this concept of stopping the smoking, getting them on an exercise bike or some type of exercise to build up their cardiopulmonary reserves. Some patients will need better nutrition, preoperatively maybe take more calories if they're malnourished, and then some psychological interventions like meditation and anxiety reducing exercises. All these things have been looked at to help improve their post-op outcomes. And there was a big meta-analysis done recently about using a high-intensity interval training prior to surgery to see if their post-op outcomes would improve. And what they did here was that they had patients go on exercise bikes or treadmills, and they found that across these 8 studies, prehab with high-intensity training led to improved pre-op fitness, which is kind of a no-brainer. Of course, if you put someone on a bike and have them exercise and you're standing there watching them, make sure they keep up with it, that should improve their fitness. But they also had fewer complications and higher quality of life scores after surgery. So it's maybe not surprising to everyone, but this is a pretty good evidence supporting the use of high intensity training to help make sure patients have fewer complications. What is a little bit different is that the hospital length of stay was unaffected afterwards. So they stayed in the hospital for a same number of days, whether or not they were on exercise prehab. So all these good things. And so the Washington Post, one of our newspapers that's read nationally, it even did an article recently about doing exercise before surgery so that we're still fit after surgery. But kind of makes you ask the question, it sounds great, but how come we're not doing prehabilitation everywhere for all these patients who are coming in and maybe they're not the fittest patients? Well, one reason is because there's a lot of differences between the different exercise protocols and the outcomes and how we study them that make it hard to support doing prehabilitation for everybody. There are different types of exercises for different patients. And so prehab is pretty loosely defined. For some types of procedures, they're going to be doing walking, like for colorectal patients tend to do more walking, but for other procedures, exercise bike is where it's at. So it's really unclear what is prehab exactly, and is it different for different surgeries? Does prehabilitation, does the effect vary by type of surgery? So here's a study about urological cancer surgery. They found that they had no reduction in their complications or length of stay or readmission rates. But other studies have shown improvements in these things with rehabilitation. So does it matter what type of surgery you're having? And then is it only for some patients who need prehabilitation or all of them? This is an article from a thoracic surgery prehabilitation. It seems that maybe some patients having lung surgery don't really need prehab because they're fit enough already. And maybe those only with paired lung function would benefit from it. So we have a lot of these kind of remaining questions that we're not yet able to answer completely. So it becomes difficult to support prehab at the hospital level. Also, is it just exercise or is nutrition part of it too? What about mental health? Is that something we should be optimizing before surgery? So some of these fundamental questions, additional ones are, should you just do one thing to optimize the prehab, or is it multimodal? Do you have to work on exercise plus nutrition plus mental health? All these things cost time and money and add to complexity for taking care of these patients. Should you have exercise be done in a supervised way, or should the patients be able to do this at home? Because it costs a lot of time for patients to come into the hospital just so they can ride a bike in front of you. But then again, if they're coming into the hospital, you're pretty sure that they're doing the exercise. If it's home-based, they might not actually carry through with doing the exercise. And how much prehab do you need to do? Should it be a month, 2 weeks? How much is enough? So a lot of these remaining questions. So how would you start a prehab program at your hospital? We try to consider the triple aim framework from the Institute for Healthcare Improvement: better patient care, better population health, and better value. So let's just touch briefly on value for a second. Value is the intersection of quality and cost. It's defined as the quality of care divided by the cost you need to deliver this care and to get these outcomes. So the higher the quality, the better value. But sometimes it costs more to do that. Things that cost a lot and only produce a little bit of extra quality, they may not have a big value. So we're trying to find things that will increase quality at a reasonable cost. But what does this have to do with prehabilitation? Well, all these things to get the patients to come in and do the exercises, optimize nutrition, optimize mental health, these things cost time and money and collaboration. These things aren't free. It's complex care because you have to go interact with extra specialists or extra nurses or other assistants to get the patients through the extra prehab. Additionally, a lot of prehab programs, at least in the United States, are not covered as a billable service. So we're doing these extra things for the patients and paying our staff to do it, but we can't bill for it. It's not considered part of the procedure. So that makes it very hard when we ask the hospital leadership to give us 2 nurses, a doctor, and a geriatrician to do these programs, because there isn't really any specific money for it. And then even after that, let's say we get the program running, it's hard to prove the value because sometimes patients are a little, they're not optimized anyway, even after prehab, or maybe they had a different type of surgery than what we were looking for. So there's so many different confounders in the process that it's hard to show that the prehab itself and the prehab alone is the thing that made a difference. We struggle with the same thing when we are trying to convince leadership about enhanced recovery after surgery. There's so many things that go into enhanced recovery after surgery, in the pre-op, the intra-op, and post-op phase of care. So many different items, the bundles, that it's hard to track down which one or two of those things really mattered, or if all things had to be done to make a difference. So we had kind of encountered the same problem with prehab. So here's just a schematic around some of the things that one can do in prehab, into pre-op, post-op, and after discharge phases of care. And if we're going to be looking into how to support prehab, we should be looking at the entire course of care and see what we can do differently here in terms of pre-op nutrition, but also how do we take care of the patients afterwards, and what happens when they go home. We should be looking to these different areas in terms of what to measure. So I'll just share a quick snapshot of our Center for Geriatric Surgery that we set up recently at the Brigham Women's Hospital. We're currently getting accredited for this, so I think they're still doing a good job. But it's a geriatric pathway for patients who are older and having high-risk surgeries. They get to have a geriatrician follow them and manage their prehabilitation in concert with a nursing, anesthesia, and surgical team. So it's a multidisciplinary project, and it spans the entire post-perioperative care period from the time the patient gets booked for surgery all the way through the time after they're discharged from the hospital and are recovering. They had to do some financial modeling to see how much this would cost and see what measures would improve afterwards. So they were able to get this done in this way, and it starts with, again, at the surgeon's office visit. They identify which patients should be on the pathway. They have one of the nurses do a focused pre-op exam, pre-op visit, and then they also integrate a geriatrician there to help make sure, does the patient really need the surgery? Do they have someone to take care of them at home? Do they have someone to make their healthcare decisions when they can't? And then adjust their meds and optimize them as much as possible before surgery. So we did that over here, and then they also did this at Duke University with the perioperative optimization of severe health program, where they did something similar to the one at the Brigham, where they had this kind of treatment clinic with geriatrics and social work, nursing, anesthesia, all of them working together to optimize these geriatric patients. And they also found that they had a reduced length of stay over here. They cut 2 days off their admissions, and they reduced readmissions by half. So, and then other patients, more patients, 13% more patients were able to take care of themselves at home without the need for being transferred to a facility or have a home health aide. So that's a big deal. So what they did with the POSH initiative is that they advertised this pretty heavily on their website. And I'm sure with their leadership that they cut down the length of stay by these 2 days, and then they cut down their readmissions with their 7-day readmissions as well. And so when you go to your chief of surgery or chief of the hospital and you propose to have a geriatrics program, you can tell them that if you do this well, we could reduce these length of stay and the readmissions, which are both big cost drivers in hospitals these days. So in order to do these things, we have to be willing to learn new skills and to take care of patients in ways that we didn't always think of before. Especially I think in surgery and anesthesia, I'm not sure we all thought about having to coordinate patients getting exercise before surgery or stopping smoking, but these things do matter. So we should be looking into taking on new roles as leaders and coordinators, managers of these systems to make sure patients can get these things beyond working inside the operating room, and to focus on value, that equation where the quality is on top and the cost on the bottom. How can we find things that have high value? Okay, great. Again, I'll save questions to think of this. Still have a bunch of slides for quality safety. So just switching gears, patient safety is defined as the freedom from injury that's produced by medical care, whether it's accidental or preventable. And here in the U.S., we found that preventable medical errors are actually the 5th leading cause of death in the United States. So that's just after accidents and before diabetes. So that's like a jumbo jet crashing every day as preventable medical errors. And the way we think about medical errors and finding them is that when we receive safety reports around the hospital, it's only just some of the problem. So for every 10 times that we don't wash our hands, or every 10 times that we give the wrong medication, you're only going to get a couple of safety reports out of that. And even then, maybe nothing bad happened to the patient necessarily. So you didn't even hear about those things. So this is a model showing that for every 1 death or serious injury, there are going to be 29 times where something bad happened, but no one died. And for all those times, there's going to be 300 times where we made a mistake, or we caught something just by chance. That was a mistake, but then nothing bad happened. And then there's, for all of those, there's 3,000 times unsafe conditions or other mistakes that put us up for a risk of having a poor outcome. So when you see 1 death or serious injury, just know that there are maybe 3,000 or 300 times that this could have happened, but just by chance, nothing bad happened. There are some types of events that occur in our hospitals, and I'm sure around the world, that we consider to be something called sentinel events. So these events are preventable for the most part, and they involve death or serious injury or the risk thereof. So one of the most common sentinel event is wrong site surgery. So this includes doing surgery on the wrong side of the body, so left leg versus right leg, the wrong level of the spine. So they're trying to go do a fusion on L2-3, but maybe they did 3-4 instead, or maybe the wrong digit. You know, we got 10 fingers. You know, sometimes patients will have surgery on the wrong finger. Followed by suicide within the hospital. So theoretically we should be able to prevent patients from harming themselves in this way while they're in our building. And then the rest are post-op complications, medication errors, and falls. Again, sentinel events are pretty serious. Half of them involve death, but the others also, they result in needing additional care, and some have permanent loss of function for these patients. 2 of the more common items that you'll see in the OR are retained foreign objects and wrong site procedures. So this is just data from, I think it's the Massachusetts Department of Public Health, and they found that there were this many wrong site surgeries and unintended foreign objects retained in the patient. So despite all of our safety protocols, these things still do happen over the years. And going back to high quality surgical care, for the patients and maybe other staff around the hospital, it just looks like the patients are having surgery and they're going to go home and everything's fine. But actually there's a lot that goes into it, right? It's all the work that you're doing to assess the risk, all the training that you've undergone and training that you're still working on to have the good technical skills for a successful operation. It's making sure that your equipment and all the people who support your equipment, the ones who clean your scalpels and your electrocautery, and people who work on all the retractors and the scrubs and all that stuff, all that goes towards supporting the patient having surgery and going home without complications. So there's a lot that goes on underneath behind the scenes that you do and that your colleagues do that make it look easy, but actually there's a lot that goes into it. So this diagram here is just to make the point that surgical care is very complex. We're dealing with things like the invasive procedure. We have team-based care, so you have to collaborate. Patients are sick. You have a lot of cases to do each day and night. There's medications from the anesthesiologist and others. All these things add to complexity for the care. And we do our checklists, we do our safety protocols, but for for some element of this, there's an element of chance. So something is just happening randomly, and there's not much you can do about it. But unfortunately, it will contribute to some patients having harm or no harm. So sometimes we can make a mistake. Let's say we forget to give the antibiotics before surgery. Some patients will actually just not have an infection, right? And other patients, you give the antibiotics at time of surgery, and they'll have infection anyway. It's hard to say, and you can't know which ones are going to have harm or no harm, but just know that there is some type of random element in some of these harm events. But what we can do about it is to focus on improving our systems and to optimize human factors engineering to make sure that we are delivering the safest care that we can. This is not about telling the surgeons and the nurses and just go do a better job. That's not a system fix. That's not going to do anything. But if you do things to make it easier to get the work done, make it so that you can make that's something that doesn't let you make mistakes. Standardizing things so that there is a lower chance of mistakes, things to make it easier to get the work done. Those things tend to improve safety. So this is a crisis checklist that we use in the operating room that helps remind staff what to do when there's cardiac arrest. Because believe it or not, without this checklist, staff can miss up to 25% of the things they're supposed to do during cardiac arrest. And over here is a decision support. It's a reminder to remove the Foley catheter after it's been in for a day. Because sometimes we forget to do that stuff because there's just so many things to do. Here are some things that we would do in the operating room to improve some safety systems. Some of it has to do with the physical location or layout of things. This is a carbon dioxide flow meter where you can just get carbon dioxide out of it. It could be mistaken for oxygen by accident, so you don't want that to happen. So we've replaced it with a CO2 insufflator. So you can deliver carbon dioxide in a controlled manner, and it won't be mistaken for oxygen by accident, because oxygen is right here. Another one is our medication safety. We have some, instead of vials, we have some vials, but we also introduced pre-diluted bags so that no one would make mistakes when we make dilutions for pressure medications. More of the recent advances in safety have to do with risk assessment, protocols, and team communication, getting people to work together on a more regular basis, get to know each other, have a standardized ways of communicating. This is just a difficult airway algorithm, so when the patients have a lost airway, this helps the team figure out what to do in an orderly manner. Another one that we have done around the world is improving surgical safety by using a checklist. Do you guys use the surgical safety checklist or the WHO ones? I'm seeing some nods. That's good. And there's really not much to it, right? It's doing a sign-in, just saying everyone, what's your name, doing a checklist on some of these items and having a conversation. And also doing this at some point during the surgery and just before we leave the room. It doesn't seem like much, but actually people were not really communicating before this. They would only do it kind of sporadically. But I make this something that we're expected to do for every case. It opens up that opportunity to talk to each other. And it was able to reduce surgical site infection, reduce reoperation, reduce risk of death, and reduce any complications overall. So something as simple as just talking to your team can produce great outcomes, more so than any new medication or any new piece of equipment. So this is where some of the frontiers are in quality and safety in the OR is working as a team, as an effective team. I will briefly touch on wrong site surgery, just because it was one of those items that I did publish a paper about this recently. I published a closed claims analysis for wrong site surgery, which means that for one of the malpractice insurers, we were able to get all the different times that their patients had a wrong site surgery, and we just kind of tallied them up and did a descriptive analysis. We know that wrong site surgery occurs in about 1 in every 100,000 procedure, and it's most of the Joint Commission sentinel events. So we did this closed claims analysis, and we did some vignettes of representative cases, so you could learn a bit about how to prevent a wrong site surgery. Again, patients who have wrong site surgery frequently need to have more surgery. So let's say we replaced a knee in one knee, but they still have a problem with the knee that we didn't work on. They'll need to be reoperated, and along with that goes postoperative pain. The most common types of wrong site surgery occur during orthopedics and neurosurgical cases. So when it's a spine case, usually it is wrong level spine, because sometimes it's hard to tell which level you're on, even when you have an x-ray. And then extremities. So sometimes we mix up left and right, and sometimes we work on the wrong finger. So the most common reason that we operate on the wrong part of the body is that you don't follow the protocol that's in place at your local site to make sure that we are doing surgery on the correct side. So sometimes people are in a rush, or there's an emergency, or there's something else going on that keeps us from following our usual protocols. And that's mostly what leads to having a wrong site surgery. Here are just three vignettes. One of them was wrong level spine fusion is because they're using a small camera, which they use all the time, but the viewing angle is very small, so it's hard to confirm what level you're actually at. So they did the wrong level. This other case, they did a knee scope arthroscopy on the wrong knee because there were multiple changes to the consent form from left to right, even though the patient was supposed to have a left knee scope. And then for hand surgery, the patient had a carpal tunnel incision instead of a left trigger thumb release, because although we are working on the correct hand, they just worked on the wrong part of the hand. So these really could happen anywhere. So again, to prevent wrong site surgery, follow your local protocols for preventing the surgery, confirm the side and side of the surgery with the patient and the surgeon and the nurse, and make sure it all matches the booking and consent form. I do have a couple minutes to show the framework for quality improvement, but I think this is probably the most important slide for the quality improvement section. It's we have to be taking a 7-step framework for quality improvement projects. The first is to recognize the risk. Right? What is the problem with our surgical site infections? Why is it important to our hospital? Why is it important to our patients? Why is it important to our leadership? Recognize the risk from different points of view. Number 2 is to clarify the problem. Go to where we do the work. Try to figure out what are all the things that go into having a surgical site infection. Is it the antibiotics? Is it the patients? Is it their prehab? Is it their smoking? Is it our wound dressings? Is it the incisions? Look into everything. And nothing beats going to where the work is done to see. And then think of opportunities to address all those things and design solutions around that. All too often, we design solutions around problems that we don't really understand, and then we end up doing projects that don't really make any sense, like 6 months after. So this is just you can look at these after, but this is a couple slides about a hypothermia project that we had in the OR recently to reduce patients who are hypothermic during surgery. So this is a diagram showing all the different things that we did, how they relate to reasons why patients are hypothermic, and how it all goes back to preventing hypothermia. So if you can make a diagram like this, it's called a driver diagram, then it's very easy to communicate how your project works. Yeah, so I think I'm pretty much out of time, but I can stick around to take a couple questions.
Okay, guys, any questions while we have 2 more minutes? Okay,
Yes,
we have,
yeah. Sorry. Thank you for your lecture, Dr. Pimentel. We have some question in the chat, if you don't mind, related to the left object after surgery. Do you still have these cases using X-rays detectable material?
Yes, yeah, we do. Yeah, we still have some of these cases. We've even moved on to having RFID chips in our gauze, in our lap pads, and we scan the patients with it after surgery. So those have mostly gone away at this point, but we still have things like small needles or fragments of items that chip off, we'll find them. Because we don't routinely do x-rays after surgery just to go look for something. It's only when we think we're missing something, but then sometimes it doesn't show up till after the patient leaves the OR, unfortunately. So yeah, retained foreign objects are still a problem, even with x-ray detectable materials.
Thank you, Dr. Pimentel. One more question from Sophia. For a few more
I want to ask you about preoperative team. Who had a last word in antibiotic prophylaxis? Is it a surgeon or is it an anesthesiologist?
Yeah, so we have hospital-wide and system-wide recommendations for what antibiotics should be given. We say that's what you're supposed to use, but realistically, the surgeon has the last word on that. But we're trying to make it more of a team discussion and to bring up those guidelines. But yeah, that's just the state of affairs right now. But yeah, surgeon driven. It's actually it's incredible because we have we give 2 different antibiotics for the same surgery, for spine surgery, only because the neurosurgeons want one thing and orthopedic surgeons want something else, even though they're doing the same type of surgery. So that's very interesting.
Okay, thank you, Dr. Pimentel. I guess, guys, we're running out of time and we're already a little bit late. So if you have any questions, please ask us later and we'll try to transfer them to Dr. Pimentel to get more information that is interesting for you. Thank you for being with us today. Thank you for this lecture. It was really, really nice. So much new material for us, new arguments for topics that are very hot now in Ukraine. We are trying to go in the direction of Western countries, and now we understand that we're on the right way. So we're very, very grateful, and we deeply appreciate that you're doing this for us. Thank you so much.
Thank you.
Thank you guys for being with us all today, and thank you for your attention and giving us your time and trying to be better. Thank you so much. See you next week. Thank you, Dr. Pimentel.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you so much.
Thank you.
Thank you.
Thank you.